Hello, welcome to this part 2 of All About 12 Leads. In the first part, we went over some anatomy and physiology of the heart, the electrical conduction system, the concept of a 12 lead, and how we have different vantage points depending on the lead that we're looking at, as well as what we're looking at with those specific waves of an ECG. What's a P wave? What's a QRS? What's a T wave? If any of those things are a little fuzzy, I recommend checking out part 1 of All About 12 Leads. In this portion, though, we are going to review rhythms. We're going to get into some actual rhythms. I want to talk about sinus rhythms, atrial rhythms, and junctional rhythms. But before we get into that, I do want to review electrical conduction pathway of the heart. So I have here at the anatomical top right portion the SA node. The SA node is the primary conduction point of the cardiac system here. So all normal, with quotation around it, normal rhythms are going to originate from the SA node, and we'll go into how you can identify those specifically. And SA node stands for sinoatrial node. Moving on down, we have the AV node, the atrioventricular node. I like to remember that because it is between the atria and the ventricles, and it is kind of literally in the middle of them. Then we're going to descend down our bundle branches into the Purkinje fibers. Now, each of these hubs have innate rates at which they like to fire. For example, the SA node likes to fire between 60 and 100 beats per minute. The AV node likes to fire between 40 and 60 beats per minute. And the Purkinje fibers, a little bit slower, 20 to 40 beats per minute. That does not mean that these things cannot go lower than that number, than their innate numbers, or exceed their normal maximum. For example, you go on a brisk walk, or you start doing something that is going to exert more energy and more of an oxygen demand, or call for more of an oxygen demand, our heart rate's probably going to go up. And that SA node will meet that demand just fine. But that does not mean that, we'll get into that. We'll get into tachycardic rhythms. I don't want to get too far into the weeds there. So let's start with actual rhythms here. So this is a review of that cardiac rhythm here. We have a P wave. The P wave signifies the electrical depolarization of the atria. So when I have a signal from our SA node, and it is going to depolarize this atria here, and that muscle is going to contract. So this signifies the electrical depolarization of the atria. The QRS here is actually made up of 3 different waves, Q, R, S, and you may see 3, you may see 2, you may not. It really kind of just depends on what's going on with that individual's heart and their electrical conduction pathway, but in a normal heart beat, you will see a Q, an R, and an S. That signifies depolarization of the ventricles. And notice it is quite a bit larger than our P wave. Well, we have a lot more force and contraction here. Again, this left ventricle is responsible for pumping blood through the entire body. And so it's going to take more of an electrical stimulus to do that, which is why that QRS is much larger. Moving down the line, we have our T wave. The T wave represents repolarization of the ventricles. So it's almost like a reset. So those ventricles can then be primed again and depolarize and have a muscle contraction. Again, this all happens very quickly. Some other things to note when we are about to get into rhythm interpretation, this R to R interval right here. So R to R is going to be the time between ventricular contractions, and we're going to measure that from the peak of one R wave to the peak of another R wave. And again, that is the time between ventricular contractions. And we're going to use that to, how would I say, we're going to use that to gauge how regular or irregular a rhythm is. Some rhythms are regular, some are irregular, and so we're going to be looking at our R to R intervals to decipher that. I also want to go over PRI right here. PRI is going to be the onset of a P wave, so the very beginning of that P wave. We'll zoom in here. Very beginning, when it just starts to go up here, we have an isometric line. Everything is in line here, in line, then it starts to go up. That point where it starts to go up, that is the beginning of our PRI, and then the end of it is going to be the very first instance of ventricular contraction here. So the beginning of our Q wave in this example. So we have our Q, R, S. And that is going to be used to discern how long it takes from an electrical stimulus originating from our atria to an actual ventricular depolarization and, in theory, ventricular contraction. So let's get into sinus rhythms. All right. In the sinus rhythm, the SA node is in charge here. So that, going back up here, these are rhythms that are originating in the SA node. So originates at the SA node. P waves are going to be consistent, upright in most leads, and by upright and consistent, I mean they're going to be just like this more likely. They're going to be consistently upright and round, upright and round, upright and round. A normal sinus rhythm is going to be 60 to 100 beats per minute, and it's going to have a regular R to R interval. So going back to that R to R interval, meaning it is going to have consistency between the Q or S complexes and consistency between ventricular contractions. So what is that going to look like? And I'll show you here. We got, all right. These points are relatively equal apart, okay? That's what that means, all right? So we have a normal sinus rhythm. It's between 60 and 100 beats per minute, regular R to R interval, and again, those P waves are going to be round and upright and consistent in most leads. Sinus bradycardia is going to be less than 60 beats per minute, and it is also going to have a regular R to R interval. So this is bradycardia, meaning slower, and so a slow heartbeat, and the innate rate of the sinus of the SA node is going to be 60 to 100, so less than 60 is going to be sinus bradycardia. Let's take that and flip it upside down here. We have sinus tachycardia. Sinus tachycardia is going to be a sinus rhythm that is greater than 100 beats per minute, and it is also going to have a regular R to R interval. It is not going to be an irregular rhythm. All right, so let's talk about, well, what about an irregular? Let's talk about sinus arrhythmia. This is going to have an irregular R to R interval with consistent, round, upright P waves. So that's going to be something along the line, here, let me use something that's not a laser pointer. That's going to be something along the lines of this here. So these are not that far apart, or sorry, not far apart, but they're not that different from one another, but they do have a difference in interval. These are not at the same cadence. They are different, as opposed to something with a normal, regular R to R interval. Moving on down the line, let's talk atrial rhythms. Atrial rhythms are rhythms that originate in the atria, but not the SA node, and anywhere else. These are run by rogue pacemaker cells that are in charge here. So what's going on here? Originates in the atria, not the SA node, as we talked about. P waves may be abnormal, missing, or replaced by flutter waves. First one is going to be AFib, or atrial fibrillation. Thing to note about AFib is that it is always irregularly irregular, meaning there is no distinct pattern, there is no predictability to it. The R to R intervals are completely wild and not synced up. There's also no discernible P waves. So here I have a depiction of what that might look like. We got QRS, T wave, QRS, T wave, and these R to R intervals are all over the place. And again, there's no P wave here. There's just QRSs and T waves. Moving down the line, A flutter, atrial flutter. Atrial flutter is going to be able to be discerned by its sawtooth pattern like flutter waves. The R to R intervals can be regular or irregular. And again, it has those sawtooth flutter waves, and that's this pattern right here. There's usually a consistent conduction. So for example, this is a 3-to-1 conduction. So for every 3 flutter waves, there is 1 QRS or ventricular contraction here, or ventricular depolarization. And these here, again, these are those flutter waves. They look like irregular P waves that are insuccinct there. Moving down the line here, we have wandering atrial pacemaker. Sometimes this is called WAP, and this is when I have multiple discernible P waves noted in a rhythm. And these P waves can be numerous shapes. They can be notched. They could be flipped upside down. They could be after a QRS. They could be completely absent. And I have some depictions of what that might look like. P waves can be in numerous shapes and places, including after QRS. And the R to R interval can be regular or irregular. You think about it, if I have electrical stimuluses originating from multiple pacemaker cells in the atria, most likely the time it takes to reach that QRS is going to be different depending on which one it's coming from. And so you might have slight variations in what that's going to look like. Let's also talk about PACs, a premature atrial contraction. This is not a rhythm in itself, but let alone what's called an ectopic beat or a rogue beat, a beat by itself amidst a underlying rhythm that is identifiable. So present amidst an underlying rhythm, P waves will likely appear different than the other P waves and most likely originates from rogue pacemaker cells. Down here, I have a depiction of what that might look like. So let's think here. We have what appears to be a sinus rhythm. We have a regular R to R interval. This is about the same from this to this, but then we have this space here, and it beats much quicker. For example, this is much shorter than this, or these. You can also note too, the P wave, the marker on this whiteboard's kind of thick, it appears notched. It appears different than the other P waves. These P waves are all relatively round, upright, round, upright, round, upright, round, upright, and then you have this guy, which is kind of notched. That means it is originating from somewhere else, a different pacemaker cell. Moving on down the line, we have SVT, supraventricular tachycardia. SVT is going to be identifiable by its very tachycardic rate, and there are no P waves discernible. So again, it's going to be tachycardic rhythm that is generally between 150 to 220, although it can be slower or faster than that. There are no discernible P waves, and the R to R interval is regular. So as you can see here, we have a fast rhythm. We have a T wave that really just goes right into another QRS, T wave right into another QRS, T wave right into another QRS, and there's no visible P wave. If this were to be irregular, this would most likely be what's called AFib with RVR, atrial fibrillation with rapid ventricular contraction. And that is atrial rhythms. And now we arrive at junctional rhythms. Junctional rhythms originate at or near the AV node. So think of junction being when two areas meet or come together, and at the atrial and ventricular junction, we have this atrioventricular node. So that is at or where this is originating. These rhythms often lack visible P waves, or they show inverted retrograde P waves. So I have shown here we have a beat without a P wave at all. Here we have a beat with a inverted P wave. And here we have a retrograde where it actually shows up after our QRS, which is interesting. But that's going to be a hallmark sign. Each of these are going to be hallmark signs of a junctional rhythm. And then we have our different rhythms here. Now, if you'll recall, the AV node innately fires at 40 to 60 beats per minute. And so when we have identified junctional beats at a rate between 40 to 60 beats per minute, that is what's called a junctional escape rhythm. When it is faster than that 60 beats per minute, it is going to be accelerated junctional rhythm, so specifically 60 to 100. When we're greater than 100, it's going to be junctional tachycardia, and then flip that. If we are less than 40, it's going to be junctional bradycardia. And something bonus we can throw in here, we can throw in a junctional escape beat. So we can throw in an atopic rogue beat here. We'll say junctional. And what that's going to be is when I have an underlying rhythm here, so we'll have a sinus rhythm. And then we have a junctional beat. So this right here would be the junctional escape beat. It is an ectopic beat outside of our underlying rhythm, which we have a sinus rhythm, but then we have a rogue junctional beat here, and we can tell that by this excuse me, this flipped P wave here. And the QRS is going to actually look a little bit different. The rest of the wave morphology will likely look a little bit different. Might not, but it's something to keep an eye out for. Everybody, that is all about 12 leads part 2. So we've gone over our sinus rhythms, our atrial rhythms, and our junctional rhythms. If you guys have any questions, comments, please hit me up with them. I love talking about this stuff, and I will see you guys in the next one. Either blocks